2. The title of the presentation is Hidden in Plain Sight.
Good morning. I'm presenting on behalf of Medicine 2, and I've titled my presentation Hidden in Plain Sight. We have a 50-year-old school teacher from Vellore who presented to us with history of dyspnea on exertion, palpitations for 3 days. She gives a history saying she had developed these symptoms on climbing 20 steps, needing to take rest before continuing. There was no exertional angina, no history of preceding fever or cough. She had 3 episodes of transient loss of consciousness over the past 2 days prior to presentation to the hospital, each episode lasting around a minute. There was no positive movements or tonic-clonic movements. There was no uprolling of eyes. She did not have any bowel bladder incontinence or confusion post each of these episodes. Past history, she is hypothyroid for 7 years on thyroxine. Family history, her father has ischemic heart disease. He passed away at the age of 75 due to acute coronary syndrome. And coming to treatment history, due to these complaints, after the first episode where an ECG, she went to a local hospital where an ECG was done, which showed only an RBBB, and hence she was discharged from that hospital. But subsequently, she developed 2 more episodes and hence came to CMC for further management. On examination, pulse was 70 per minute, regular, all peripheral pulses were felt. BP was 130 by 80 in the right arm in supine, and 1 minute and 3 minute standings were 120 by 80. There was no pallor. Her cardiovascular and respiratory and abdominal examination were within normal limits, as well as a central nervous system examination. Summarizing, this is a 50-year-old teacher from Vellore who presented to us with a history of recurrent episodes of transient loss of consciousness with a history of exertional palpitations and dyspnea. What would be our clinical diagnosis? So in this, I'd like to consider 3. One is recurrent syncopal attacks. Syncope can be of 3 kinds. One is neurally mediated, which is a dysfunction of the autonomic system, orthostatic hypotension, or cardiac syncope. In this patient, our most likely diagnosis that we considered was a cardiac syncope in view of her presenting complaints of transient loss of consciousness with palpitations. Lower down, we had considered episodes of seizures and transient ischemic attacks. Moving on to our baseline investigations, all the baseline investigations that we did were unremarkable. She did not have any electrolyte imbalance. We did an MRI brain, which was normal, and a carotid Doppler, which ruled out an obstructive plaque. Coming to the ECG, does someone want to have a go at this ECG? I'll see.
This broad QRS complex with RSR pattern and
What's the axis?
it's a left axis deviation.
What about the QRS? You mentioned something, okay? What is that QRS?
RSR
Okay, you're correct. There is a broad QRS with an RSR pattern, a slurred S wave in the V6 leads, and a positive R in one and a negative in AVF, suggestive of a left axis deviation. If we look closely, we can also find that there is a mildly prolonged PR interval. So coming to what we already discussed. So there is a widened QRS in V1 with an RSR pattern in leads V1 to V3 and a slurred S wave. Along with this, there are also findings suggestive of a left axis deviation with a positive QRS in lead 1 and a negative in AVF. So what does this tell us? These wide QRS with an RSR pattern is suggestive of a right bundle branch block. We usually see RBBBs on our OPD basis, and we don't don't do anything about it. But this is an indication to have a closer look at the ECG. This patient had an RBBB with a left axis deviation. Coming to what are fascicular blocks. So once the conduction impulse starts from the SA node and reaches the AV node, it goes to the bundle of His and branches out into the right bundle branch and the left bundle branch, which involves the anterior fascicle and the posterior fascicle. If there is a block in the left anterior fascicle, the direction of initial conduction will be inferior and later it will come superior. That means the inferior lead should have a first positive deflection followed by a negative deflection, while as it comes superior, the anterior lead should have a negative deflection followed by a positive deflection. So this will lead to a left axis deviation with a positive QR in lead 1 and a negative in AVF. So a left anterior fascicle block will cause a left axis deviation. While similarly, if there is a block in the left posterior fascicle, the direction of activation of the impulse is superior initially, followed by inferior, which means that there will be a positive wave in the anterior leads and a negative wave in the inferior leads, followed by a subsequent positive wave. So if there is a left posterior fascicle block, there will be a right axis deviation, while if there is a left anterior fascicular block, there will be a left axis deviation. This is what I have already explained. So a left anterior fascicle block will cause a left axis deviation, and a left posterior fascicle block will cause a right axis deviation. So in this patient, she had a right bundle branch block with a left axis deviation suggestive of a RBBV with a left anterior fascicle block. Now the PR interval was also more than 200, which means that she had a bifascicular block with a first degree AV block as well. This is referred to clinically as an incomplete trifascicular block, and it represents conducting system of two fascicles with a delayed conduction through the AV node as well. Why is this important? So if we look at high risk features which warrant hospitalization or evaluation of syncope, we can see that bi or trifascicular blocks are indications for admission and evaluation and not on an OPD basis. So this patient was actually asymptomatic in between the episodes. She did not come to the emergency department as well. But this warrants admission for evaluation. Now, a bifascicular block indicates a structural heart disease and extensive fibrosis of the system. What we need to remember is that patients who present with a syncope have a 17% annual risk of progression to a complete heart block. And in the context of a syncope, a bifascicular block is an indication for admission. Coming to the varying causes, this can be ischemic heart disease, structural heart diseases, MIs, cardiomyopathies, amyloid, sarcoid. These are varying causes that we had considered in this patient. Coming to the echo that we did under medicine was normal. We did a Holter study which showed two events of high degree AV block as well in this patient. So coming back to a patient, this patient presented to us with a bifascicular block with a prolonged PR and an intermittent high grade AV block. We transferred her under the EPC and she underwent a permanent pacemaker insertion yesterday. She's planned for a cardiac PET tomorrow for etiological diagnosis. My learning points would be look for an RBBB by itself should not have an axis deviation. If we see an RBBB with an axis deviation, it indicates that there is either a left anterior fascicle block if there is a left axis, or a posterior fascicle block if there is a right axis deviation. In the clinical setting, if a patient presents a syncope, she should be admitted for monitoring and likely pacemaker insertion. But asymptomatic bifascicular blocks with a first degree AV block is not an indication for PACE.
Good. Thank you, David. One question. How do you explain the palpitations, recent onset palpitation on severe physical exertion?
I was thinking whether that was related to the block should not explain it.
She had normal LV systolic function on.
Yes, sir.
And that you went back and asked, and that's a recent onset symptom. It's not been there earlier.
Yes, sir. It was not there earlier.
Okay. I think the most important point is that somebody who presents with syncopal episodes, don't send them away from the emergency department. And then this patient's ECG showed a RBBV with a LAFB. So shouldn't have been admitted for further evaluation. What did the Holter contribute